We have to start on time so that we can finish on time and allow the next set of speakers to take over. So our course is on on foreign bodies in general, the different presentations and the way we manage them. We have the whole lot of the entire spectrum of presentations in different parts of the eye, and we have with us today the faculty. I'll be one of them. I'm the chief instructor. Can I control it myself, please? I will, yeah. So we have Dr. Satyamurthy. I think he's on the way, yet to arrive. Dr. Kumar is right here. Dr. Aniket Shastri is also here. He was here a couple of minutes ago. He's on the way. And Dr. Apurva Ayachit. So we have a mix of seniors and juniors so that we have a proper perspective of the entire spectrum of both the diagnosis and the management. So the topics that we are going to speak today are on epibulbar foreign bodies, anterior segment foreign bodies, posterior segment foreign bodies in the courts and beyond. And I will be speaking on how not to miss an intraocular foreign body to begin with. So the history taking and examination are very important. Like metal on metal activity is something that we have to ask for. A subconjunctival hemorrhage or a wound of entry is something that we have to look for. A hole in the iris is pathognomonic of an intraocular foreign body. Cataract, which can be which can be sometimes localized and sometimes generalized, total, can also have its presentation that way. And a track in the vitreous of either blood or exudate, and uveitis or even endophthalmitis. And these are the commonest presentation ways that a foreign body will present with. Of course, this is unmistakable. There is already siderosis, and therefore you know that there is a foreign body inside for a long time. So, but if that was the typical way we take the history and do the clinical examination, sometimes our case may beat your skills. The cases can be so different and atypical that history may not be contributory. Examination too may be apparently negative for foreign body. We have imaging to our rescue. We have X-ray, the good old X-ray which we used to do in the pre-CT era or the pre-MRI era. There is some information on location with the limbal ring that is sometimes fixed to the limbus. It is sutured to the limbus, and the patient is sent for an X-ray of a PA lateral view, PA Waters view, and a lateral view, so that we are able to see the meridian of the foreign body and the location in terms of distance from the limbus, so that we can do a cut-down approach or an intravitreal approach, and thereby remove the foreign body. Ultrasound, of course, by its echo density with shadowing, persistence at lower gain, especially if it's a non-metallic foreign body, you can pick it up with ultrasound, and a 3D construction is possible with some softwares. CT scan in 2 planes is also very accurate, and we are able to localize the foreign body, especially to know whether the foreign body is inside the eye, intraocular or extraocular. Of course, we have to avoid MRI when the metallic foreign bodies are strongly suspected. But one thing I must say here, especially for the postgraduates here, which I learned from Dr. Kumar, is before cataract formation occurs, before dispersion of vitreous hemorrhage, before vitritis sets in, the best way to locate or to confirm the foreign body presence, the invaluable information that we get is from indirect ophthalmoscopy. So don't forget on indirect ophthalmoscopy, no imaging technique is superior to IDO if you can see the foreign body yourself actually there in the eye by clinical examination. Some pitfalls. These are all the typical cases that I was talking about. But what I'm going to talk about in the next 6-7 minutes is about some pitfalls. I'll start with some examples. Unexplained uveitis in a 7-year-old. A 7-year-old comes with a history of recurrent redness and pain in the right eye. His vision is only 3/60. AC cells 2+, vitreous cells 3+, peripheral vasculitis, blood-tinged vitreous opacities. He was investigated for childhood uveitis and vasculitis, all were negative. He was given a course of steroids. vitreous opacification progressed, and therefore vitrectomy had to be planned. But look at the turn of events. What we saw under GA was there was a hole in the iris, a track in the lens, and an intraocular foreign body in the vitreous cavity. This is something that I've shown time and again in different conferences, but it is very important for us not to forget that we have to see these children as a whole like we do in adults. For example, this child was not cooperative. He was a 7-year-old irritable child, could not cooperate for a slit lamp examination. And this is what we were all seeing all along without a proper upper lid retracted, the superior limbus was not at all seen, and therefore we missed the foreign body. What we missed was a hole in the iris, which was the entry site and a track in the lens. So it is very important that these children are subjected to sedation for the sake of complete examination and maintain a high index of suspicion in all possible intraocular foreign bodies. And retrospectively on history taking, the father was a garage mechanic, and the boy used to visit to give the lunch box to the father. So this is what the story is like, and therefore I think there's a lot of learning from this case. Let's see this other case. History of injury with a stone 2 months prior, history of surgery elsewhere for traumatic corneal tear 2 months ago, and after repair, he had been sent to us for keratoplasty. But what we found was that the patient just had PL, and the view of the fundus was hazy, the pupil was not dilating, there was this corneal opacity which was sutured, which was actually a sutured corneal tear, and there was a retinal detachment on ultrasound with a suspicion of a foreign body because of the hyperechoic lesion there with a shadow. And this is what we found intraoperatively. Can you mute it, please? Mute it. So we had to make an incision like we used to do for the intracapsular cataract extractions in the past. And this is how we could extricate or extract the foreign body from the eye, stuck to the ciliary region, a piece of stone which was stuck because it was there for 2 months. It was stuck very strongly to the ciliary processes, ciliary body and the retina, peripheral retina. And we had to extract it by actually cutting the retina as well. So see, you can actually see the retina. And of course, this patient underwent VR surgery. I'm not going to show you that video. Patient underwent VR surgery and could recover some useful vision. This was a case referred as a case of phacolytic glaucoma. You can see that there is a total cataract. There is a small hypopyon, which can be there because of the phacotoxicity of the particulate matter of the cataract. There was no definite history of trauma. There was congestion and total cataract like this. But what we had missed was a corneal tear, which was actually the wound of entry of the foreign body, which was so small and inconspicuous that it could not be seen against the white background of the cataract. So what all that the anterior segment surgeon had to do was to evacuate the cataract, suture the wound, suture the corneal wound, evacuate the cataract, and send to the vitreoretinal surgeon. So the lesson is see the cornea and not just through the cornea. So there is a corneal tear which was missed because of the white background, which was very small. That was the point of entry, site of entry of the foreign body, and therefore you have to look at the cornea and not just through the cornea. This was the imaging that was conclusive of foreign body just before we as vitreoretinal surgeons did the surgery. So this was a case referred to us as a case of heel chorioretinitis. Patient had 3/60, thoroughly investigated and worked up for uveitis and given steroids for 2 months. I'm sorry about the photograph, it is quite dull, but I'm sorry. So what actually the lesion was, the video is not playing, can you help me? Yeah, it's playing now. This is an old video, and that is why we have a limited field there, a 30-degree field. Actually, it was not a chorioretinitis scar, it was an encapsulated foreign body, and you can see it was right at the macula in a capsule, which later got absorbed and the patient recovered 6/18 vision from 3/60 to 3/60. By 2 months, it had improved to 6/18, which is very, very heartening. So this is a case of floaters with 6/6 vision, N6 vision, referred to us as a case of active toxoplasma retinochoroiditis, treated with cotrimoxazole for a month in vain, of course. Patient came to us with floaters when the floaters increased, and there was paracentral scotoma. So what exactly was the thing behind was, I'm sorry, where is this? So this was also a case of foreign body. You can see that on imaging, we discovered that there was a foreign body, and this patient had to be explained all the pros and cons of the surgery because it was so close to the macula. Patient had 6/6 vision, and you can imagine what if there was an accident during surgery or a complication during surgery, but this patient did very well. The foreign body was removed from its site of lodgement and finally removed the forceps. So this was a mine worker, injury in a mine blast activity, presented 3 months after the injury, PL only vision, total cataract, ultrasound was negative for any foreign bodies, but vitreous hemorrhage was seen, and X-ray was negative for foreign body, and this is what we found on table. When we did the vitrectomy for vitreous hemorrhage, there was this stone particle, which is usually non-radio opaque or radio lucent or radio transparent, and therefore could not be seen on either CT or X-ray. And this is how we removed it with an extrusion because it had a rough surface, could not be held. We did not have the basket forceps at that time. This again is an old video, maybe 12 years ago, 12 years back. This case was done, and it was removed from the translimbal approach. So this was a 33-year-old female working in the fields, and a thorn injury that she had sustained while traveling the tractor at night while coming back from work. All that we could see was a brownish discoloration under the conjunctiva. And when we explored, we found that this was actually, when we opened the conjunctiva, attacked the muscles and saw the brownish discoloration was actually the tip of the long organic foreign body or a thorn that had gone right into the vitreous cavity. So this is something that can happen and can be mistaken for just a melanosis of the conjunctiva. Patient was not very symptomatic. Finally, I always like to show this. Let me show you the one on the right. I'm sorry. So this is an intravitreal foreign body. That's actually a nematode, which was live, and it's not a big deal to remove this. And please play the slide on the right now. Please play the video on the right. Some of you seem to be controlling more than me. Not this, the next one. Yeah. So this was a subretinal foreign body in a lake of retinal detachment, swimming in a lake of retinal detachment. A subretinal biologic foreign body or a nematode. You can see that I had to do a retinotomy to remove this nematode from the subretinal space with the cutter itself, with the vacuum of the cutter, and regurgitate it into the vitreous cavity from where it was removed in a more controlled manner with the flute needle. Okay. So this is the foreign body at the end of the nematode, which came out at the end and was still live. So to summarize, detailed history taking is important. Occupation is very, very important, not only of the person who has been affected, but also of the family members. A careful slit lamp and fundus examination. Always make an attempt to see the foreign body with the IDO, and use of imaging to confirm, rule out, or localize a foreign body is very, very useful and should be done. A high index of suspicion in all trauma cases, needless to say, is very important for any unexplained uveitis or endophthalmitis. Thank you very much. So I would invite questions now, or can we have it at the end, whatever the co-panelists, co-instructors can please come over here now that we have enough audience. So we go over to the next talk by Dr. Anikesh Shastri, consultant cornea, cataract and refractive surgery at the M.M. Joshi Eye Institute, Hubli, from where we all come, except Dr. Kumar, who is in Bangalore having his own solo practice, who will be speaking to us on epibulbar foreign body.
Right. Good morning. I want to thank Dr. Guru sir for making me a part of this. And from the heroics and heroism of Guru sir, let's come to some common problems with a common man. So I'll be speaking about epibulbar foreign bodies. And usually most of the time, this is what is the scene of crime when it comes to epibulbar foreign bodies. It's always the cornea, foreign body sensation or redness. And we need to do a closer inspection on this, and when we do a closer inspection upon the lids, this is where the main culprit is. This is one that's causing the scene of crime, and this is something that's very common that come to us. And the possible sites of impaction are actually the lower fornix, then the upper fornix, and then the bulbar conjunctiva. And methods of removing of this non-impacted foreign bodies would be a simple irrigation. Would help it, or you can use a moist cotton bud or a forceps. So you can just dip your cotton bud with an antibiotic solution or even a lubricating will do, and just wipe it with in the upper tarsus, and your foreign body is easily removed. It's usually most 9 out of times quite superficial. Video. Okay. Then something that's like an insect head or an impacted foreign body on the conjunctiva, sometimes even a vegetable matter, then it would not come out with a cotton bud, and you may have to use some forceps to take it out under topical anesthesia. And always try to remember that whatever you do at the end of the process, you should always stain the cornea and the ocular surface with fluorescein. So you want to know, one is what is the impact of, what is the kind of injury that has occurred on the cornea, and second, always don't stop and assume that there's only one foreign body. There can always be multiple foreign bodies. Depending on the injury that you see on the cornea, you can always go back and evaluate. So there are some occult foreign bodies. And multiple linear corneal aberrations, because here the foreign bodies are usually transparent to translucent on the upper tarsus. There can be a chronic pyogenic granuloma that keeps waxing and waning. There could be a granuloma associated with a scleritis as well. And it can turn out to be an organic foreign body or a wooden foreign body, which is not easily, which can be diagnosed only with an excision biopsy. So there are some conditions when we have to ship the patient to the OR, especially when the foreign body is encapsulated. It's more than 48 hours, causing some kind of reaction. You feel that it is embedded. Yeah, that is when you have to take it in an OR with a subconjunctival injection. You can just do a simple excision followed by conjunctival suturing. Whenever it is associated with a scleral perforation, when you suspect a scleral perforation, a metallic foreign body, a wooden foreign body, or a sharp metal foreign body, multiple foreign bodies in the cornea and conjunctiva and ocular surface in cases of blast injuries, it has to be taken to OR. Though you cannot take out everything, but at least whatever is superficial and try to pricking has to be taken out. And a large size conjunctival or a corneal associated lacerations have to be done under the OR. All children, ideally, if the symptoms doesn't resolve in 48 hours, have to be taken to an OR. This is a case of diagnosed shield ulcer, which is not healing, and when taken to a OR, found a broomstick there. So this case was unique because it was not a bilateral VKC, it was just a unilateral symptom. So VKC in kids unilateral is quite tough to find. Some special considerations are kids sometimes may need a double eversion of the eyelid because you can have a foreign body that is embedded deep inside the upper fornix. So you do a double lid eversion of the desmas retractor, and there can be some synthetic granulomas that have been noted in the literature. And one of the things which you see very often, very common sometimes during seasonal basically, is our ophthalmia nodosa. So this is a condition that due to the embedment of the insect hair, actually the caterpillar hair, and either it's a trauma either directly with a insect or it could be just transmitted to your hands. Okay, it causes a nodular reaction basically because of its mechanical effect, because it's very sharp and needle-like, or due to its toxin. And it can cause other intraocular and posterior segment complications as well. So that is the reason why this has to be meticulously removed first and foremost, because it causes severe reaction. There are many times you may not be able to appreciate the foreign body, so you have to give a course of topical steroids and oral anti-inflammatory to reduce the chemosis, to reduce the edema, and then these friable structures can be removed. It has to be done over multiple settings, ideally 24 hours to 48 hours of repeated evaluation of the patient. And it requires quite a long follow-up, at least wait till 1 to 2 months. We have one patient, after everything else, we removed one foreign body 2 months later, a caterpillar hair. So the patient comes usually with just chemosis and corneal edema and fluorescein stain positive. And this is where you have to go to the OR, especially for the upper lid, where you have to pick these. This is post-steroid treatment. Once the chemosis comes down, then you can pull these small pinhead-like lesions that appear dark on the surface, but they are quite deep inside the conjunctiva. This requires multiple sittings. This is just a single video, but it's over a period of 6-7 days. Anything that's on the inferior fornix can always be done under topical anesthesia on the slit lamp. This is another interesting case, treated with only topical antibiotics and some low-dose steroids for a unilateral case of discharge and conjunctivitis, sort of a conjunctivitis for 5 to 6 days. And on slit lamp evaluation, when we evaluated, it's found out that these were small larvae. Okay, this is ophthalmomyiasis, and these are all small translucent because of the bot flies, most commonly seen, especially in farmers and shepherds, but it can also be seen in those seasonal areas in the villages when even a muddy water or just mud enters your eye. And these are to be taken out, of course, topically with your in the OR. One thing which I have observed is these, if you try to take out immediately with 1 drop of paracaine, they tend to move very fast. So what you can do is you can just flood the eye for around 15-20 minutes with topical anesthesia. Then, I mean, it's my personal observation, I have observed that they start moving quite slowly. So that's when you can just pick it up. Just to cover up, finalize, this is the last case where patient was treated for approximately 2 weeks for a case of keratitis with a whole cocktail of antibiotics and referred to us. A large epithelial defect, absolutely no infiltrate, lid edema, chemosis, and he had a huge thorn in his upper fornix. So once we took that out, and within 6 days, his edema is resolved and lesions. So thank you. Your epibulbar foreign bodies can range from a single foreign body to multiple foreign bodies. Always try to evaluate the upper lid, and at the end, never forget to stain your cornea. Thank you.
That was amazing, Aniket. You made it so interesting with good illustrations. Any case of ophthalmic nodosa, have you lost the eye due to endophthalmitis?
It can occur, definitely.
No, it can occur, but in your experience, you have such a vast experience. Have you had any case of endophthalmitis following caterpillar hair?
One case we had ophthalmia nodosa where superficially we evaluated, and later we tried, it was quite deeper, and there was evaluation into the subscleral space and in the this thing, but I don't personally recall any case. But it has been noted that all cases of ophthalmia nodosa have to be evaluated by comprehensively because there are chances of vitritis and endophthalmitis.
I have handled a case of endophthalmitis due to caterpillar hair infestation, if I may call it that way. It had been treated elsewhere with multiple settings of removal of these caterpillar hair from the tarsal plate. But when the patient started getting intraocular inflammation, it was referred to us, and it went relentlessly beyond, it slipped away from our hand. In spite of every effort that we did, intravitreal antibiotics, multiple vitrectomies, somehow we could not save the eye. So that is one thing we should keep in mind. Caterpillar hair can be very dangerous if it enters the vitreous cavity. Any questions from anybody? Anything you want to add, sir? KVS, KP sir and Kumar. Thank you.
Thank you, sir.
So we'll be having Dr. Satyamurthy now to speak to us on anti-segment foreign bodies. Dr. Satyamurthy is Director of Cornea Refractive Surgery and Eye Bank in M.M. Joshi Eye Institute, Hubli. And he looks after he's a medical director of the Dharwad branch of M. Joshi Group of Hospitals.
Thank you, sir. At the outset, I would like to thank Dr. Guruprasad for giving me this opportunity. In fact, corneal foreign body, anti-segment or any foreign body for that matter is an emergency, and it should be treated at the earliest. So foreign bodies can be inorganic and organic. Inorganic, it can be metallic and non-metallic. So I'll not go into these details as they are depending upon the speed at which the foreign body hits the eye. It can be either on the surface of the cornea or it can enter the anti-segment, as you see the things clearly here. Now let's see one by one. What if it is on the cornea? If it is just loosely laying on the surface, then probably all that we have to do is just wash with saline or using a magnetic spud or a cotton bud, we can remove it. Sometimes it is embedded deeply into the cornea. It goes, if it is below Bowman's membrane, then that will result in scarring. At the same time, there is something called as a Coates white ring, as you see here. That is nothing but the iron, say in a metallic foreign body, this is an iron piece. So the iron and the fibrotic remnants which form a grayish white circle around the foreign body, and then unfortunately this doesn't disappear even after removal of foreign body and treating with steroids. The foreign body can be removed as you go obliquely in an anesthetized sac and then take out the foreign body. I will not get into this. Now what is most dangerous is this rustering, what you are seeing here, that has to be, especially ferrous foreign body, it will leave behind rust 4 to 6 hours after the impaction with foreign body. The rust starts and that has to be removed. Otherwise, patient will be symptomatic and epithelium will never heal in that area. So that has to be removed. All that we have to do is just remove the edges and then peel it off with a forceps, or one can use a brush, the corneal brush. Yeah. Now the problem is, what if there is a central foreign body? Why I am saying this? Because if the foreign body is in the superficial stroma, and then it forms a scar there, and then along with that white ring, and if we try to remove the foreign body, as you see here, and try to dig too much into the cornea, then we are going to leave behind a central scar which can hamper patient's vision. So one has to be very careful while doing this. In case if we don't follow any aseptic precautions properly, our patient may present with an ulcer like this following fall of foreign body. Like in the previous session, talk, Dr. Aniket showed a very nice multiple foreign bodies started on the cornea. This is what you get following blast injury. And all the superficial foreign bodies you can remove. Deeper foreign bodies, in case if they are inert, like glass pieces or something, we can leave behind. Otherwise, removal itself can cause a lot of scarring. And so we'll have to observe this patient regularly. And now this is a case where the patient came with foreign body like this, and no, play it, no? Why it's not playing? Yes, right. Right. You see a foreign body there at the limbus, the peripheral cornea, and then it was removed finally. Since it was through and through, one stitch had to be taken. Already the infiltration had started, so put this patient on intensive antibiotic therapy, topical antibiotics for a longer period, and one has to do seedal test in every case of foreign body to make sure that the foreign body is just, whether it has entered or not, or the corneal wound is open or not. So now this is coming to the next this is a vegetative foreign body where it's quite common because most 70% of the people, they live in rural areas and they come with this kind of thing, maybe a sugar cane or some wooden piece which has gone inside, especially in the farming community. All you have to do is just make an opening at the fag end of this and then take it out with a forceps like that. And at the same time, make sure that by seedal test, this track is not open. Okay. Right. Thank you. This is another case where you can see this. There's a foreign body inside, and then you can see the lamellar hole, lamellar tear there, and then the track is opened and the foreign body is taken out. This is a vegetative foreign body. And then so here there's a caterpillar hair which you can see. I mean, this is the hair follicle which is stuck in the cornea, which is removed like this. And now, Dr. Aniket showed beautiful slides on this particular thing, ophthalmia nodosa, following the injury with caterpillar hair. So now let me just go a little deeper into this particular field. In fact, you asked a question where the caterpillar hair can cause vitritis or any post-segment complication. Caterpillar hair, which is otherwise called spine or setae, it has got that hollowness in which there is a venom, and the spicules, which are those thorns which are directed upwards towards the distal end. So the caterpillar hair is known to migrate deep inside. So whenever the patient comes for follow-up, some may disappear, but some, if they have disappeared, they might have entered the post-segment also. That is how patients may come back with quite anti-segment, but vitritis. Ophthalmic nodosa is a very known entity. Of late, it is coming down, but it is more common in those people, motorcyclists or those who ride bike without helmet or without any eye protective glasses. It can appear like this, or sometimes there is, superficial superior corneal aberrations where the answer lies on the lid. You have to avert the lid, and it was beautifully shown by Dr. Aniket. Removed a lot of those things. Sometimes bees, this is what is the Hymenopteron group of organisms, that is bees, wasps, and then biting ants. So they cause problems by hitting the eye. So if you see here, this is the stinger, and then the bee, when it hits the eye, it leaves behind the stinger and venom. So the venom will contain histamines, and it will contain what is called a melittin, which increases inflammation in that area, and then hyaluronic acid, which allows it to spread. It may look like corneal abscess, but it's not so. All the mainstay of treatment is, one is removal of the stinger. Second thing is, you'll have to treat with steroids, topical and oral, intensively. So it can present with diffuse corneal edema, or it can present with cataract also. It can present with antechamber reaction. sometimes the endothelial decompensation may start. It may not yield to your treatment. So in that case, you probably will have to resort to graft, endothelial grafting. So now this is another case where the foreign body was lodged in antechamber. So it was removed by making an incision here, as you see here, and then the whole thing was removed. So any foreign body, if it is visible, it is always better to remove that. And then now coming to foreign body which is lodged in the angle, one should have high index of suspicion, like Dr. Guruprasad said it multiple times, because foreign body in the angle is not visible, and sometimes you may miss the track in the cornea or in the peripheral cornea or limbus or sclera. Then many times you will have to do gonioscopy, and then only you will come to know that there is a foreign body. X-ray per se may not be a very sensitive thing. It is said that about 40% of these foreign bodies are seen on X-ray, even though it is radio opaque, but otherwise you are likely to miss. So what is more important is this CT scan, which definitely, which is very highly sensitive. And then of course you have UBM, but you can't do UBM in every case. So the gonioscopy is a must in all these cases. And now the foreign body which can enter the eye, if it is say ferrous foreign body, that can cause siderosis like this, what you are seeing, or it can cause traumatic cataract. I'll show you a video on this. So thanks, I'm thankful to Dr. Kumar for sharing this with me. You can see that is the foreign body, and there is another foreign body which is seen deep inside. Okay, so probably it has hit and gone just into the lens, and it has not pierced the posterior capsule. So this was removed using magnet probably. And then finally, the traumatic cataract was managed, and then intralenticular lens was. So this is just to show that foreign body can enter like this, a large foreign body through the cornea from limboscleral to the corneoscleral on either side. And then as you see here, it's been a little difficult to take it out, even though it is protruding out. Yeah, this is my last slide. So this is the foreign body which is there. So I would like to conclude by saying proper management strategy is very, very important. And of course, a high index of suspicion in those cases where eye is irritable, and you'll have to rule out the presence of foreign body. And then, of course, appropriate investigations are to be done. Thank you very much for your patient listening.
Thanks, Dr. Satyamurthy. Just one question I have, and then we can probably ask the audience also to participate. In cases where there is a foreign body that is more into the posterior cornea and the antechamber than on the surface, so do we dig into the cornea and bring it out from the external approach, or should we remove it from the intracameral route?
Fine. So it's a very good question. So now that foreign body to enter into the antechamber, I mean to the cornea, and from cornea protrude into the antechamber, there has to be a track on the cornea. So all that we have to do is open it and then make a paracentesis wound and put a lot of viscoelastic, dispersive viscoelastic, where you can protect and you can push the foreign body up. That is the easier way of removal thing, and then later on you can remove the viscoelastic substance. This is what I do in most of the cases.
I think we can make it case-based, depending on how much of it is inside and how much we can
that time you
access
can just
from
on the
outside.
table, you can take a call and then do it.
Thank you, sir.
Thank you.
So we now go over to posterior segment foreign bodies by Dr. Apurva. Dr. Apurva is a young consultant at Joshi Eye Institute. She is also an avid researcher and a very prolific surgeon. Dr. Apurva, please.
Hello. Yeah. Thank you for the opportunity, sir. Today I'll be talking about evicting posterior segment intraocular foreign bodies. Most of the foreign body cases that we get are because of patients indulging in metal on metal activity in garages or lathe machines. I'm presenting from my laptop.
I request one of the audiovisual people to be there at the podium to get it started.
It's connected. Yes. Is it format नहीं है ना? ये साइड का नहीं जा रहा है ना? साइड का नहीं जाएगा। एक सेकंड। या ठीक है। हाँ। So pars plana vitrectomy is the standard management by VR surgeons. It can tackle all types of intraocular foreign bodies. It enables precise visualization. It makes surgery controlled and predictable, no matter how unpredictable it may seem on table because of various associated pathologies like retinal detachments, giant retinal tears, endophthalmitis, and sometimes even panophthalmitis. This is a scenario that we can encounter where there is a firm encapsulation of the foreign body by the coats because of an inflammatory reaction. So whenever the media permits, if possible, pre-operatively, even in fact several days before, we can opt to laser around this foreign body and its encapsulation, so that during surgery at PVD induction, which again has to be at the margin of this foreign body, it can prevent a tear formation. These can be notoriously attached, very adherent to the coats, and can cause iatrogenic tears and a retina that refuses to settle. So if we are doing a preoperative laser, it has to be done several days prior so that the laser has time to act and take up. So this is a video of a retinal tear which has occurred due to the ricochet of the foreign body, and this has to be lasered before the PVD induction. Like I said, at the time of PVD induction, at the border of this tear, the retina can get lifted. So to prevent that, we can do a laser intraoperatively around the margins, and then before PVD induction, we can take care of it. So of course, if the patient has been rendered aphakic in the first stage of the surgery, a limbal route is also preferable because the limbus is much more forgiving than the pars plana, and it can accommodate much larger foreign bodies and especially non-magnetic foreign bodies. Also, you can float it up with PFCL and use an extrusion with high vacuum if it is not coming with any forceps or a magnet. This I am talking about non-magnetic foreign bodies. A buckle or band is up to the surgeon's discretion depending on the support that the base needs, especially if it is inferior retina and inferior vitreous base. Total encerclage with a 240 band or a segmental buckle, a large one like 279, can also be placed. So to make this presentation a little more interesting, I'll be presenting my challenging cases that I've encountered in the past 2 or 3 years. This is the first challenging case. This was a 48-year-old gentleman with history of trauma to the right eye with a metal-on-metal activity. There was severe pain, redness, and swelling. The patient also had intractable vomiting. The vision in the right eye was only PL, and the ocular movements were restricted in all gazes. There was proptosis, severe chemosis, and a lot of anterior chamber reaction. Now, this was the B scan of this patient. We can see that there is a very obvious foreign body with the back shadowing, and it has a very large spike on the A scan as well. And you can see that there is a retinal detachment as well. There are a lot of exudates, and here you can see a T sign. So this is a very infected case, and it is a panophthalmitis, and it has an intraocular foreign body. Now the pre-operatively systemic cover was given of antibiotics, painkillers, and the patient was explained very guarded visual prognosis, and the surgery was started. We can see that there is an entry wound through which there is a necrotic retina which has already come out. So I just did cut the retina flush with the sclera. After that, the AC exudates were cleared. The lens was removed, and you can see just behind the lens there is a lot of necrosis, and there was a lot of necrosis, so we cleared that. Now when we go in, there is no view at all. There is a lot of vitreous hemorrhage, some necrotic tissue seen. These lights don't help either. So it will get better in a couple of seconds. So I decided to scrape the cornea and go in, and saw that this was the situation. There was a totally bunched up necrotic retina. I'll just show that again. This is all bare RPE that you can see. And now when I put PFCL inside, the necrotic retina opens up a little, and you can see the prized foreign body right in the center. And I chose to remove all the necrotic retina at the base to reduce the load of inflection. Here is the foreign body that is lying right in the center like some treasure. So since the patient was aphakic, I chose the limbal route, made a clear corneal incision, and under visco, I removed it with a handheld magnet first, and at the limbus used an external magnet and removed this foreign body. So this was a very challenging case with incarcerated retina which was extruded, and we had to cut it flush with the sclera first, then go inside, remove all the exudates, and then find that the retina was having a 360-degree giant retinal tear with necrotic retina. And I couldn't save this eye. I just did an FAE and came out, hoping that at least this patient didn't undergo an evisceration. So the eye was saved. So this was post-op 1 week. A retina photograph could not be obtained because of the haze. But now you can see that he's actually opening his eye, and the movements also have been restored to a large extent. So that was a case of panophthalmitis, GRT, and an intraocular foreign body. This is the second challenging case which I saw in 2021, 3 years ago. This is a 38-year-old man with the trauma to the right eye 10 years prior, uncertain about the mode of injury. He had neglected this eye and had blurred vision since 5 to 6 years. The vision was only hand movements, and there was a posterior subcapsular cataract with posterior synechia. The ultrasound was done, which showed a total retinal detachment. This patient was posted for right eye synechiolisis, cataract surgery, and RD surgery. Now this was the first surgery that we do. We retina surgeons usually talk in terms of which surgery, first surgery, second surgery, third surgery, because we know we'll go in again. So yeah, that apart. Now you can see that there is a lot of vitreous haze opacities which we took care of, and then there was this nasal incarceration of the retina. Here you can see that there are retinal folds nasally, and this one here. So I released it from its incarceration, did a thorough base shaving, went in, saw there were chronic folds at the macula, and I managed to attach this retina. Now, after 2 months, the patient had a redetachment with lifted retinectomy edge. Now this time, I had to use iris hooks. I thought I was doing a reasonably decent surgery, removing all the membranes meticulously. Lo and behold, at the nasal edge of this retina, at the retinectomy margin, anterior retinectomy flap, there was something shining back at me, glistening, and I was horrified to find a human head in the box, Morgan Freeman. I found a intraocular foreign body in this eye. I was as horrified as him. Under this anterior flap, there was a foreign body, and it was hiding under the retinectomy edge. So now if I see this eye, you can see that there's a lot of siderosis, definitely, and that's of course in hindsight. Then we did a 360-degree retinectomy, managed to remove the foreign body as well as attach this retina. But like I said before, it redetached again. This is the third surgery, removed membranes. And this is just to show how aggressive PVR can be in an eye that has had a foreign body which has not been so inert, because siderosis is also inflammatory, and inflammation can be a great setting for PVR and recurrent detachments. So this patient underwent 3 surgeries and probably didn't come back to me because of the poor prognosis. But this is just to show that the foreign body can be hiding under flaps of the adrectinectomy edge. So now if you look back, this is definitely a siderotic appearance of the retina in the first surgery itself, and we should have suspected a foreign body. So the lesson was to look inside the box and search every nook and cranny of the eye for neglected trauma cases. So this is the third case where I was a little wiser, I think. This boy had a neglected trauma in the left eye for 15 months. Vision was only PL. Fortunately, looked carefully, and on clinical examination itself, there was an IOFB. There was a GRT and open funnel RD. These are telltale signs of siderosis, like KVS sir was showing in his presentation. This is a typical pigmentation spots of ocular siderosis. So you can see that, and you can be sure that you will find an iron foreign body inside. After cataract removal, put an infusion, 3 ports pars plana vitrectomy. You can see how siderotic even the vitreous is, how pigmented it is. And you can see this is the foreign body when I did an indented demonstration for the onlookers in the OT as well here. This is the foreign body. And you can see how pale and yellowish brown the retina is. That is also a siderotic retina. Here there is a GRT, and after base shaving and freeing all the GRT edges from adherent vitreous, the foreign body was now tackled. This has probably become demagnetized after a long time in the eye, and I tried using a handheld magnet and removing it till the sclerotomy site, but the external magnet could not manage to remove it. And you can see how pale the vessels are. These are all telltale signs of siderosis. These are all toxic effects of the ions, ferric ions. Now, I've placed the PFCL inside, and again I used a magnet, intraocular magnet, tried with an external magnet, didn't work. Although I can feel the metal on metal, it's just refusing to come out. So I went in with the intraocular magnet, made sure I removed and freed all the vitreous around the foreign body as well as near the base, and then chose to remove this foreign body through the limbus under viscoelastic protection. And then sutured the sclerotomy and the limbus and completed the vitrectomy. You can see that the retina is free from any membranes, and vitreous base shaving has been done meticulously. You can see that it has settled under PFCL, and now it's settling under air as well. The retina looks very good. I have completed the laser. And after that, I inject oil, and the patient is attached so far. So evicting posterior segment intraocular foreign bodies is through pars plana vitrectomy, which has to be thorough with base shaving and checking the subretinal and pars plana areas. You can choose to add a belt or a segmental buckle depending on the need for support by surgeon's discretion. It is a Pandora's box. It can have detachment, multiple tears, GRT, endophthalmitis and panophthalmitis like I showed. And it can be a classic case for recurrent detachments. Thank you so much.
Thank you, Dr. Apurva, for that wonderful compilation of difficult cases, especially the one with panophthalmitis, where you removed the foreign body, even attached the retina, necrotic retina, and saved the eyeball integrity at least, if not vision. I think that was a good, very good case, a great feat, I must say. in saving the cosmesis of the patient. I think all of the cases also were very good. Any questions from anybody? Okay, we'll finish with Dr. Kumar's talk on foreign bodies in the courts and beyond. Dr. Kumar is a very experienced, prolific pan of from Bangalore, and he is the proprietor of the Kumar Netralaya in Bangalore, and very, very busy. We'll, I think, listen to him now.
Thank you, Dr. Guruprasad, for including me in this instruction course, and I must thank all the members in the audience for staying back and searching the venue, because we've had a lot of difficulty getting to the topography of the halls. So I must thank all in the audience for your presence here. We come to the last talk, which is Evicting the Intruders, and I'll be talking about foreign bodies in the courts of the eye and beyond. While I was trying to prepare for this talk, I found a very, very exhaustive classification system, but I made my own. So ocular foreign bodies can be classified as either intra-global or extra-global, and those that are intra-global can be intraocular, and a useful term that I found was intramural, which is foreign bodies in the courts of the eye, and those that are extra-global can be either in the eyelids or the orbit. Coming to the foreign bodies in the courts of the eyeball, exhaustively and extensively this has been discussed. Those in the cornea have been discussed by Dr. Aniket. We will be discussing about those in the sclera. Apart from clinical examination, which has been adequately emphasized, ancillary testing in the form of ultrasonography, and particularly a spiral or a helical CT scan in the case of suspected metallic foreign bodies, and MRI where wooden, glass or plastic foreign bodies are suspected, do come into the picture. So this is a picture of an ultrasound showing a pre-retinal foreign body. An interesting phenomena that has been observed on the ultrasound when the foreign body is impacted in the courts posteriorly is what is called as a double optic nerve head sign. This is in fact a pseudo double optic nerve head sign because of the shadowing due to the radio dense foreign body in the courts. And if another section, if it is a longitudinal one in which this is appearing, you take a transverse section, then this disappears. This double optic nerve head shadow disappears. So this is a pseudo double optic nerve head sign that has been described in ultrasonography. And CT scan, of course, is vital, particularly with smaller foreign bodies. A helical or a spiral CT is very useful in detecting these foreign bodies. Some of the red herrings, which have already been emphasized, but particularly with regard to deeper penetration, if there are no or minimal anterior segment signs, the likelihood of deeper penetration is very much there because there's no loss of the momentum. One must carefully look for the scleral entry wound, which may not be a wound as such, but there might be indirect indicators such as a conjunctival pucker, pigmentation, or a bleed there. The scleral wounds are more likely to have foreign bodies which penetrate deeper and get impacted in the courts. Double perforations, and we may be very much preoccupied with the ghastly external wounds such as the adnexal wounds, but these patients may also be harboring intraocular or intramural foreign bodies. Take a look at this patient whose anterior segment was absolutely quiet, nothing at all, and even the posterior pole was looking normal, but in the lower temporal periphery he had this foreign body with a pre-retinal hemorrhage and the foreign body impacted in the retinas and the sclera. We have all been witness to the broomstick injuries and graphite in schools when there is this impaction along the sclera and it's just removed off, and the distal portion of the foreign body may still remain impacted in the walls. So those impacted in the sclera can be, I have made this classification myself, it may be predominantly intraocular, which means the bulk of the foreign body is intraocular with only a small fragment in the sclera, or it might be astride the sclera, that is half within and half without. These are the toughest foreign bodies to handle. I used to refer to these as cardiac function tests for the vitreoretinal surgeon. So these are very tough to handle. There will be very often a large posterior eye wall dehiscence and the eye will be hypotenuse. And to deal with this posterior perforation site itself will be a task. Various things have been used to seal this large posterior opening, such as Abgel, and many times a prophylactic chorioretinectomy is recommended in these cases. And the third category of foreign bodies in the courts could be predominantly extrascleral or extraglobal. We will just share two case detail. This is a 42-year-old gentleman, a metal scrap dealer, that's the vital point in the history, who complained of sudden onset of pain, redness, and floaters in the left eye. And this was the picture he presented with what looked like an orbital cellulitis kind of a picture. His movements were also restricted. And this was the hemorrhagic chemosis in the eye. And he had a nasal vitreous as well as intraretinal and what looked like subretinal hemorrhage as well. Because of his history of being a metal scrap dealer, we were wondering what to do next, and obviously an ultrasound was the first thing that we did, which only showed vitreous hemorrhage, but there was no evidence of any intraocular foreign body. He was treated with oral antibiotics and NSAIDs, particularly in view of the fact that he had some symptoms of orbital cellulitis. This led to the adnexa looking normal after about 5 to 7 days. But then he developed a dispersed vitreous hemorrhage with very poor vision. This was when we resorted to to a CT scan, and that showed a large radiopaque foreign body wedged between the globe and the orbital tissues. This kind of a picture is usually described with firearm injuries, but this was probably a metal which had got wedged, and this happens due to sudden deceleration of the momentum in the foreign body as it gets wedged between tissues, and there is a kind of a concussion injury. The sclera remains intact, but the choroid and the retina tears. This was a classic, we did a vitrectomy, and these were the post-operative pictures, and this is the bare sclera there. So the sclera doesn't tear, but it's the choroid and the retina that tears, typically described as retinitis clopeteria. This was another 28-year-old male who complained of a sudden onset of diminished vision with vitreous hemorrhage, but he had a small entry wound in the front of the eye. And on CT scan, this was lodged in the posterior sclera in the coats of the eyeball. And this is an intraoperative photograph which showed a retinal tear, and there was a large mass of fibrous tissue with hemorrhage there, just distal to the vitrectomy cutter tip. We did laser around that impact, around the foreign body tear, and then we did a chorioretinectomy, as you can see here, because it was largely extraocular. We did a chorioretinectomy. You can see the ILM folds at the macula, but he retained fairly good vision. And he's doing well. He recently developed a cataract that was appropriately dealt. These are some of the other pictures from our collection of large foreign bodies which were wedged in the coats of the eyeball. Some of these cases are really very tough to handle, particularly those that are partly within and partly without. These are some of the pictures taken from the net. These are extra-global foreign bodies, but I just wanted to highlight that many times the external wound may be very subtle. It might just be a small scar or a small hemorrhage and may not be grotesque as in these patients. So we have to be very alive to the possibility of an adnexal foreign body, and depending on the case, we may have to choose either a CT scan or an MRI. And when discussing about foreign bodies in the coats and beyond, many times the foreign body may well have gone into the brain as well, as you can see in some of these cases, the CT scan on the top right corner. And subtle foreign bodies may be missed on CT scan because it appears radio lucent, and a linear streak of radiolucency on a CT scan should generate a lively suspicion of a wooden foreign body that is better picked up on an MRI scan. So in conclusion, intraocular foreign bodies in the coats or intramural and beyond may sometimes be more deceptive than actual intraocular foreign bodies itself, which we may be able to visualize with indirect ophthalmoscopy. As has already been emphasized multiple times, detailed history, a painstaking examination, and a sixth sense or a common sense is very, very critical so as not to miss. And if we miss, then this becomes indefensible in a court of law. So those are the concluding points that I would like to make. Can I play this video, please? Yeah, this is a patient who had a double tear. Actually, it had grazed the sclera and then again twice at the back of the sclera. This was the foreign body which was removed, and then we switched. This was some of the cases that I did in my earlier part of my career. Now I would rather suture up the proximal wound and then go after the foreign body. But those days we were energetically running after the foreign body. It's better to get a hold on the globe by suturing, and then of course we have to deal with these patients appropriately with a belt buckle and then go in and treat the internal problems, the vitreous adhesion around the site, intraocular endolaser, and appropriate tamponade as may be necessary. And this is another case where the foreign body was lodged at the limbus, partly outside and partly within. And we used a forceps to gently tease it out so as not to cause a profound, instantaneous, precipitous drop in intraocular pressure in these patients. The videos from this point onwards, the next subsequent videos, I would like to thank Dr. Guruprasad for lending it to me. And the subsequent videos are from his collection. These are some foreign bodies which are lodged in the coats of the eye. You can see that this is a relatively older one. And this was another one that was lodged, embedded in the muzzle and causing, I presume it was causing movement hindrance and diplopia, and therefore the patient, this had to be removed. Fairly large metallic foreign body that was embedded partly within the muscle as well as in the adnexilla. And this is something similar to what I showed up front. This had gone in proximally and then again come out more posteriorly. And then the sclera was sutured. Yeah. Thank you very much for your patience.
Thank you, Dr. Kumar, for the magic show that you showed.
Guru, I had a question myself with regard to the first video that I had borrowed from you. That was predominantly extraocular without any injury to the sclera. So the point would be, if there is a foreign body which is clearly extraocular or lying on the episcleral surface, would we leave that behind or not do anything? For example, in the patient with the retinitis clopetaria, which I showed, I didn't do anything with that foreign body because it is wedged in the orbit. And whatever infection was probably caused by the foreign body was treated with the antibiotics. And we hope that would take care of it, and we just left it there. So in your first case also, if it was such a scenario where the foreign body was predominantly episcleral in location, would we just choose to leave it behind as well?
See, the fact that you can see that there is a ring, limbal ring, shows that I have tried removing it from inside. I have done a vitrectomy because the foreign body was visible from inside also.
Okay.
So this was a patient who underwent surgery for almost an hour. After 1 hour, we gave up and did the extraocular retrieval method. So it was mostly extraocular, which we could not identify before surgery. We had to do vitrectomy, look for it, in fact, we even tried to remove it, extract it, but it was not coming because it was predominantly extraocular. And only when we failed removing it from inside did we actually turn the eyeball and remove it from outside. So I think this is the story as it goes for that particular case.
And if there is a posterior foreign body which is half within, straddling the coats, half within and half outside, would you rather take a bet on the external approach, disinsert the muscles and go posteriorly, or try the intraocular route? Because dealing with that large posterior wound is a big problem. We had discussion on this. Rajesh has used Abgel to seal the wound there and prevent hypotony.
I think the advantage of doing it intraocularly or to the vitreous route is that we can have a good control on the retina. We can see the retina, see how much of damage is done to the retina, address that part, maybe do a retinectomy, chorioretinectomy around the foreign body exit area so that it doesn't cause traction and future retinal detachments. rather than just removing it from outside and leaving it that way. So I think internal approach is better, provided it is coming. If it is not coming because of the sheer shape of the foreign body, then we can do a retinectomy, do all that is required to prevent a retinal detachment from inside, and then go out to remove it from outside.
Yeah. The other thing which I wanted to ask was, because one of the things is, if it is totally beyond the eye and there is no evidence of any intraocular damage, we just leave it alone. So we should never go after the foreign body.
No need to remove it, because once it is extraocular, the chances of sidrosis are zero. Even if it is in the coats, I think there is a small risk of endophthalmitis, especially if it is in the choroid. But if it is purely in the sclera, then also probably the risk of sidrosis is very less. So you can take a call depending on the exact location of the foreign body, the size of the foreign body, and the chances of it causing sidrosis. Any questions? Now that we have, see, the limbal ring was the pre-CT era, was used in the pre-CT era, which was a beautiful technique actually. It was actually innovated by my mentor, Dr. M.M. Joshi. Nobody else I have seen using it that way. He used to, created one with the help of a blacksmith, created a ring with two eyelets for suturing. He used to stitch it on the sclera, episclera at the on the limbus under topical anesthesia, send the patient with a patch to the radiologist next door, get the X-ray in the PA, Waters view, and the lateral, with lateral looking up, lateral looking down, so that if there is movement of the foreign body along with movement of the ring, it means that it is intraocular, and if it is not moving, then it is extraocular. So that was the kind of concept that we had during those days, and it used to work very well. Of course, CT came later and ultrasound came later, and we now are more dependent on that.
I used to like limbal rings a lot during my first and second year residency days, because that was the only surgery that we used to get.
So I think time is up. If there's any question, one last question. Dr. Sudhakar, would you like to add something, because you're such an experienced ophthalmologist from Bellary? Anybody else wants to say anything? Yes, sir. Thank you, everyone. Thank you, all the co-instructors. Dr. Sudhakar? Thank you. I thank all the co-instructors, all the audience for sitting through 1 hour and 15 minutes, the hall coordinators and the audiovisual people. Thank you very much. Please come over to the dais for a group photograph. I request Dr. Sneha to take the photograph.